welcome to this high-yield explainer. Today, we're bridging basic pharmacology and clinical practice to totally conquer statin-induced myopathy. If you're a medical student prepping for your boards or a junior doctor looking to sharpen your ward management skills, you are in exactly the right place. We're going to break down the biochemical why behind the clinical what, giving you a highly structured visual roadmap to absolutely nail this topic. All right, here's our bench-to-bedside roadmap for today. First, the biochemical bottleneck. Then, pathophysiology of muscle toxicity. Third, identifying vulnerable patients. After that, clinical action and algorithms. 5, pharmacological profiles and prescribing. And we'll wrap it all up with a high-yield rapid synthesis. Let's get right into it. Section 1, the biochemical bottleneck, targeting HMG-CoA. We've got to start at the microscopic level, right? To really understand exactly how these life-saving drugs end up disrupting cellular chemistry. So as you know, statins act by inhibiting HMG-CoA reductase in the liver. That puts a halt to cholesterol synthesis, which fundamentally alters cardiovascular disease prevention. By basically throwing up a massive stop sign right at that crucial, rate-limiting step, drugs like atorvastatin and rosuvastatin drastically lower hepatic cholesterol production. And hey, this is the intended effect, right? This is the mechanism that literally saves millions of lives. But here is the crucial clinical alert. Blocking HMG-CoA also starves the mevalonate pathway. You simply cannot block the road to cholesterol without also inadvertently cutting off the synthesis of coenzyme Q10. It's a classic biochemical bottleneck, and honestly, it's the absolute foundation of the myopathy side effects we see in our patients. Moving on to Section 2, pathophysiology of muscle toxicity, mitochondrial failure. Let's see how this builds from a simple biochemical bottleneck into some profound cellular pathology. Like, what actually happens when we run out of CoQ10? Well, CoQ10 isn't just some simple vitamin. It's literally the critical fuel for your cellular power plants. It shuttles electrons between complex I and complex 3 in the mitochondrial electron transport chain. Without it, ATP production grinds to a halt. Plus, it acts as an antioxidant shield, which is incredibly vital for tissues demanding massive amounts of energy. Tissues like, you guessed it, your patient's skeletal muscles. This illustrates the whole domino effect brilliantly. Dropping Q10 leads straight to mitochondrial ETC failure, unleashing reactive oxygen species that literally tear muscle fibers apart. You can trace the cascade yourself: statin to HMG-CoA inhibition, down to lowered mevalonate, depleted Q10, and boom, mitochondrial failure. The resulting reactive oxygen species, or ROS, essentially trigger a self-destruct sequence in the muscle tissue. So here's the kicker. As these muscles break down, they dump dangerous levels of creatine phosphokinase, or CPK, and myoglobin right into the blood, setting the perfect stage for a lethal acute kidney injury. When you're out there on the wards, you aren't looking at ROS under a microscope, you're looking at lab values. And CPK and myoglobin, those are your flashing red warning lights that the kidneys are about to take a massive hit from toxic myoglobinuria. You're going to see this present clinically on a sliding scale of severity. On the milder end, most patients just get myalgia, so muscle pain but with normal CPK. But if that CPK climbs past 10 times the upper limit of normal, now you're in myositis territory. Past 40 times? That is full-blown rhabdomyolysis. And definitely don't forget IMNM, an incredibly rare but severe autoimmune reaction that persists even after you stop the drug. Section 3, identifying vulnerable patients, risk factors. Since not everyone develops myopathy, how do we predict exactly who is at risk when we're doing our rounds? We really need to know who our vulnerable targets are. You have to weigh inherent patient vulnerabilities, specifically things like untreated hypothyroidism, against pharmacological dangers, like, say, co-prescribing powerful CYP3A4 enzyme inhibitors. Hypothyroidism naturally lowers baseline CoQ10, meaning a statin will push those patients over the edge way faster. And looking at the drug factors, anything that inhibits the CYP3A4 enzyme, like erythromycin or amiodarone, is going to dramatically spike the blood concentration of statins like atorvastatin or simvastatin. Look, we all share the trauma of memorizing those CYP interactions for the boards, right? But right here is exactly where that knowledge pays off and saves a patient. Okay, lock this high-yield board pearl into your memory right now. Absolutely never combine gemfibrozil with a statin. The compounded risk of rhabdomyolysis is just extreme. If you're a medico taking an exam anytime soon, this is basically guaranteed to show up. It's a classic lethal combination that you have to actively avoid in your prescribing practice. Section 4, clinical action and algorithms. ward management. Let's transition from just identifying baseline risks to actually taking definitive clinical action when your patient complains of muscle pain. This is where the textbook meets the patient chart. Follow the CPK levels strictly. Normal means you can continue the statin, but anything over 10 times the upper limit means you stop the statin stat, push IV fluids, and aggressively monitor renal function. And check out the clinical rule here. Always rule out hyperthyroidism before attributing myopathy solely to the statin. If they're in that middle zone, say 3 to 10 times the limit, you can try reducing the dose or switching to a different statin, but close, weekly monitoring is absolutely non-negotiable. Now, this algorithm naturally leads us to one of the most heavily debated questions in modern clinical practice. If the statin depletes CoQ10, shouldn't we just prescribe a CoQ10 supplement to fix the myopathy? I mean, it seems like a perfectly logical fix, right? Just replace what the drug takes away. Well, what's really interesting here is the deep disconnect. The biochemistry behind supplementation makes perfect sense, but the clinical trial evidence, it remains incredibly mixed and inconclusive. While some randomized controlled trials show a mild benefit for simple myalgia, there is currently no formal guideline-based recommendation to prescribe CoQ10. From an exam perspective, make sure you know the shared pathway mechanism of depletion, but understand that the clinical utility of supplementing is still totally up in the air. Section 5, Pharmacological Profiles, the Statin Showdown. Let's master the pharmacology to make sure we're choosing the exact right statin for the specific patient sitting in front of us. Because as we all know, not all statins are created equal. Notice how pravastatin completely bypasses CY3A4 metabolism, which makes it way safer for polypharmacy. Meanwhile, rosuvastatin offers the highest potency with an impressively low myopathy risk. This table is absolute gold for your daily clinical decision-making. Got a patient on a ton of CY3A4 inhibitors? Pravastatin is a remarkably safe choice. Need aggressive lipid lowering without a massive muscle risk? Rosuvastatin is your go-to. Oh, and never forget, they are all category X for pregnancy, absolutely contraindicated. While atorvastatin remains the most widely prescribed option for primary prevention, you've got to be extremely cautious with simvastatin's higher myopathy risk at its maximum dosages. Looking at regional prescribing patterns, particularly in places like India, atorvastatin dominates, usually dosed at 10 to 80 milligrams once daily. But if you see an older patient rolling in on 80 milligrams of simvastatin, your myopathy radar should immediately start pinging. Section 6, High-Yield Rapid Synthesis. We have covered a massive amount of clinical and biochemical ground today, so let's lock it all in. This is your 60-second mental checklist before you hit the wards or walk into the exam hall. Remember the shared HMG-CoA pathway bottleneck. Strictly avoid the lethal gemfibrozole combination. Know that pregnancy is an absolute category X contraindication, and always rule out hypothyroidism first. If you hold these core concepts in your head, that Q10 depletion causes ETC failure, that the clinical spectrum scales all the way up to rhabdo, and that choosing the right statin can bypass dangerous enzyme interactions, you are going to manage these patients safely and effectively every single time. Which leaves us with this final provocative thought regarding the future of personalized cardiovascular medicine. If statins are fundamentally mitochondrial bottlenecks, how will the next generation of lipid-lowering therapies evolve to protect our most vulnerable patients? As we learn more about mitochondrial vulnerability and individual genetics, the one-size-fits-all approach to statins is definitely bound to change. Keep questioning the mechanisms, keep checking those CPK levels, and stay curious. Thanks for joining me on this explainer. Keep studying hard, and I'll see you in the next one.